Look, that's a good question. I have to admit that I'd have to go back to the literature to see whether that's been covered. Infliximab is a very serious treatment to give to a child, with lots of potential complications. In Australia, we have a lot more familiarity with using IVIG in a number of other conditions. And so it's a readily available treatment. I don't know for sure the answer to that question, I'll be honest. But our guidelines certainly suggest starting with IVIG. Yeah.
So another small request from you, whether you can repeat the slides with the less likely features of Kawasaki disease and then explain it a little bit further so
Sure.
that they can catch.
Let me see if I can go back and do that. Okay, I'm going to go back here. Let's go here. Less likely. I'll find that slide. Where are we? Here we go. Yes. So if everyone can see that now, so this is really clinical skills. Okay, so it's really important. This is clinical medicine where, these are not laboratory criteria. These are just careful examination. You shouldn't be having exudative conjunctivitis. Okay. Now, exudative conjunctivitis is very common in children in lots of conditions, and particularly lots of viral infections. I'm sure all of you have seen this before, but it's very common for patients to have, adenovirus, viral conjunctivitis, just in association with a number of general viral infections of childhood. So be aware of that. This is not something we should be seeing in Kawasaki. Now, exudative pharyngitis, you can see with hand, foot, and mouth. Most commonly, we start to worry about streptococcal infections when we see this. This is not what you should be seeing with Kawasaki. Okay, so if you're seeing a large amount of exudate on the tonsils, for instance, that's not typical. Ulcerative oral lesions, and you'd all recognize, so this is common with also, again, hand, foot, and mouth, but this is common with HSV-1 infections. There are some other viruses which occasionally will cause this as well, but it's not a feature of Kawasaki. I think most people would recognize that a bullous or vesicular rash is a different entity. It's not typical. We had a look at that polymorphic rash earlier on of that child. So there are a lot of manifestations of rash in Kawasaki, but bullous and vesicular rashes are, to be quite honest, as a clinician, I like them because they narrow the diagnosis down a lot. Okay, that's an uncommon finding. You're really narrowing yourself down to only 2 or 3 entities, to be honest, once you've got one of those. So I don't think many people would make that mistake. But it is important to recognize that generalized adenopathy is not typical, and that includes splenomegaly. So if you're starting to see those sort of changes, well, that brings in a whole lot of range of entities. One thing we would think about in our community would be EBV. Certainly VZV can do that as well. And then, you have to start to also think about, even malignancies potentially at that point in time. But EBV would be the most common cause of generalized adenopathy for us. I don't believe that's a feature of dengue, but you would be able to inform me better. I don't think that's right. Yeah. Any other questions?
Yeah, thank you so much. So a little about the adults Kawasaki disease. So
Yeah.
some of our colleagues are interested to know how common is Kawasaki disease among adults who haven't developed the disease in their childhood, and also how do they present and the cause of it. Yeah.
Yeah, look, I'm sorry because that's outside my range. I've never seen. I'll have to be honest. I've never seen Kawasaki disease in an adult, I'd have to delve into literature to find that out. In fact, I'd be very interested if any of the people watching have had experiences of that, because I practice adult emergency medicine as well, and I've been doing so for about 15 years. I've never seen a case of adult Kawasaki.
All right.
My understanding is a lot of it's to do with an immune response which is more prominent in younger children. Of course, it doesn't mean, one of the things in adult emergency medicine that we have to be really aware of is just to appreciate that this is the reason why some people are having cardiac disease in their 20s and 30s. And once you understand that, sometime here in Sri Lanka, I've also, been doing adult emergency medicine, and, there are certainly some populations where you see cardiac disease younger, coronary artery disease. But, if you're seeing that in the 20s, it sometimes can be quite interesting to go back and reflect on their childhood experiences. It may have been an unrecognized Kawasaki. Any other questions?
Yes, thank you. So they're interested to know if the initial echo of a child is actually normal, if the child has symptoms of Kawasaki disease. In the follow-up, after how long do you have to repeat the echo to see?
No, thank you. That's a really good question. It's actually, there should be an echo. Well, I can only tell you what we do here in Australia. But actually, if you want to go to the AHA guidelines, it has very, very specific directions on this. Most children will have an echo at the beginning of the diagnosis. They will have a further echo prior to discharge, bearing in mind that a large number of patients will respond to IVIG relatively quickly. I've been showing you some of the more interesting stuff, but the standard Kawasaki, usually within 2 to 3 days, they're really improving. And so they may be in our hospital system for up to a week and have another echo on discharge. And they're usually referred to a cardiologist, and I would suggest that they would normally have an echo at least twice in the first year after diagnosis. That might depend upon what findings were there at the time of that last echo before leaving hospital, so that if you have got quite significant findings at that time, then they may have closer follow-up. And so it's a variable practice as well. If their echo is completely clear on discharge and they didn't show any cardiac manifestations, then the follow-up may not be as close as that.
So that sums up my next question, which is on the follow-up of the children with Kawasaki disease. So it's purely purely on the findings of the echo, or are there any other things or clinical manifestations that we can think of considering the follow-up?
The majority of what is happening to the child during Kawasaki resolves. It's the cardiac stuff which is really more persistent. It's interesting to reflect on whether there's other arterial disease also prevalent. But in general, and looking through literature, there's not a lot discussed about people having renal artery stenoses or other vasculitides. There seems to be some predisposition to affecting those medium-sized arteries in the heart, and of course valvular disease as well, which is specific to the heart. So the majority of follow-up, once the acute phase is finished, the child will, recover, the liver will recover, all of those other kind of third spacing issues will improve. The primary follow-up is going to be cardiac from that point in time.
So a little clarification. So one of our colleagues have stated that in the criteria of both classical and complete Kawasaki disease, the fever is generally more than 5 days, which is included in guidelines. But she wants to know whether it means that the fever less than 5 days almost rule out the possibility of Kawasaki, or is it still comes into the differential diagnosis? Yeah.
It's a great question, and you can see from my first case that I presented that this is a real issue. What do you do when you see a patient on day 3 that is already manifesting all of those signs? Okay, they're not meeting the criteria for Kawasaki yet, but you're getting very, very confident that that's what they're going to have. What would we do? We would just talk to rheumatologists. Okay, that's where we would go. And I say that because the treatments are not light treatments. Okay, it's not like giving a dose of ceftriaxone. You're going to start giving IVIG, high-dose aspirin. If you want to start making these sort of decisions without being sure, you need to have some very specialized advice on board. So we would never do that. I think it's important to recognize that can happen, but I wouldn't be giving IVIG to patients on day 3 without talking to someone specialized. There's obviously a good rationale to do that, because the earlier you start the treatment, if you can turn the process off, the less likely there are that this inflammatory process will lead to cardiac complications. So it's not a bad idea to do that. It's just that you have to recognize that you're stepping outside a diagnostic criteria. And I think in medicine, we all appreciate that in general, that's where you want to have other colleagues assisting you, because you don't want to be treating a septic child on day 3 with IVIG and have a catastrophe after that. Does that make sense?
Yeah. Thank you so much on that. So a little bit out of your scope, I think, on this question, because they want to know about your experience in Australia. So this is not regarding Kawasaki. So one of our colleagues want to know the first-line treatment of Guillain-Barre, GBS, in Australia. whether IVIG or plasmapheresis is the option that is being used there?
That's a great question. It's changed over time, actually. Plasmapheresis is not as easy to access. So I can give you some experience of where I work normally in Australia. We wouldn't be able to plasmapherese a child very quickly. And so in the times when we have had a Guillain-Barre patient, occasionally what happens is you give IVIG and then you transfer them to a facility where plasmapheresis can be adequately performed. How it works in a more specialised centre, whether they go for plasmapheresis straight up, I'm not sure. I have to answer. I couldn't answer that at this point.
Yeah. And a small query about the case we discussed earlier. So they want to know whether we discussed a case about the Kawasaki Shock syndrome. And in that case, they want to know whether we can consider severe MISC as a differential diagnosis.
Yeah, it's a great question. You know, because when this stuff came out about MISC, you know, and you're probably all aware, everyone looked around and said, this looks a lot like Kawasaki. And it does. It does look a lot like Kawasaki. And interestingly, the pathological basis may in fact be very similar to Kawasaki as well. I mean, one of the really interesting things about Kawasaki is that we still don't really fully comprehend what triggered it, what triggers it. You know, as I mentioned in the epidemiology earlier on, there's seasonal variation. You know, there's you know, ethnic predisposition. So it's complicated, isn't it? And you know, it seems to, with the seasonal variation, we typically think that might be a certain virus circulating at a certain time. And then when this whole MISC stuff turned up during COVID, I think a lot of people were thinking, you know, is this a Kawasaki type illness? Now, MISC, however, tends to also occur in older children. So it's not limited to this younger. So it's not the same entity, actually. Kawasaki is much more common, as I think I said at the beginning, under 4, but in those first few years of life, it's the most common. MISC, you know, is not quite like that. Lots of similarities. And very interestingly as well, when MISC started, you know, when they first started recognizing this in the UK and the US, they were basically giving Kawasaki type treatments, straight up. Because I think that's because the rheumatologists very much thought they were dealing with something which was extremely similar. In Australia, we've had a number of MISC cases, but it's really patterning off now. It seems to be much more common with the Alpha and Delta strain. I think with Omicron and its variants, which are now more common circulating strains, you know, for the last almost 2 years in Australia, we haven't seen as much MISC. I'm not sure if that's the same as everyone is experiencing here in Sri Lanka or not. I'd say that there will be a number of PhDs done on MISC and compared to Kawasaki. And I think hopefully what it would lead to is some better understanding of Kawasaki as well. I think, you know, it's interesting earlier on you were asking about, you know, using IVIG versus infliximab. I think, so even though I presented, you know, some of the evidence, I think the more astute of you would have recognized that they're not really large case numbers either. You know, it's not a very, very common illness, and it's often very difficult to get the sort of level of evidence you want with an illness like that. And so a lot of the guidelines, even the AHA guidelines, you know, still work in a fairly consensus type pattern rather than on level A evidence for all the treatments. I think that's important to recognize. And so, you know, when you look at these treatments, for instance, that were given to the intensive care patient that had shock syndrome, and you think, well, they gave IVIG, then they gave infliximab, then they gave methylpred. Do they actually know what they're doing? Well, it's a good question, but the reality is that it's not a lot to guide it. So that's the difficulty with that sort of medicine.
Yeah. Okay, thank you. So that is, I think, the end of the shared questions for today. So we would sincerely like to thank Dr. Thomas Georgeson. He's an adult and pediatric emergency physician from the Canberra Hospital, Australia, for his excellent lecture and for this precious time that he shared with us. Thank you so much, Dr. Georgeson, for your contribution. And
you're very welcome. It's a great honor. I really enjoyed, and hopefully I'll see some of you around in Sri Lanka, and I do come to Lady Ridgeway Hospital every now and again, so thank you. I really, really appreciate you inviting me. It's wonderful.
Okay, thank you very much. So we'll move on to the end of the questions. So end of the session. So please find the link of your post-session questions in the chat box, and please kindly give your feedback and answer the post-assessment questions, and then you will be receiving your e-certificate for participation. And please note that if you haven't received your certificate in the next 3 days, please contact us through us. Okay, so thank you so much, Dr. Georgeson, once again for your contribution, and we wish all of you a wonderful weekend. Okay, have a good day.
Thank you very much. Thank you.